younger than 65. Now this definition is of ischemic stroke. Actually, we use the term stroke more for ischemic stroke rather than intracerebral hemorrhage or subarachnoid hemorrhage. So here for stroke we will consider as ischemic stroke. So the WHO definition of a stroke is sudden onset of focal neurological deficit, sometimes can be global, lasting for more than 24 hours or leading to death with no apparent cause other than that of vascular origin. This is an old definition. Now the 2013 American Heart Association and American Stroke Association definition of a stroke is an episode of neurological dysfunction caused by focal, cerebral, spinal or retinal infarction. They have incorporated cord infarction, spinal cord infarction also, and retinal infarction also in the definition of the stroke, ischemic stroke, based on pathological, imaging or other objective evidence in a defined vascular distribution and or clinical evidence of a cerebral, spinal cord or retinal focal ischemic injury based on symptoms persisting for 24 or more than 24 hours or until death, and other etiologies are excluded. So this has to be very clear. Stroke is an episode of neurological dysfunction caused by focal, cerebral, spinal, or retinal. These are the three areas. Either the diagnosis is based on pathological evaluation like biopsy, imaging, or other objective evidence in a defined vascular distribution. Means you can define it in a vascular territory, whether it is an anterior cerebral artery infarction, whether it is an MCA infarction, or it is a PCA infarction, or it's a pica or posterior inferior cerebellar artery infarction. You should be able to explain the symptoms in a vascular territory and or clinical evidence of cerebral, spinal cord, retinal, focal ischemic injury based on the symptoms which persist for 24 hours or more than 25. This is the cutoff. The symptoms have to persist for at least 24 hours or more than that to categorize it as a stroke. Now, what is TIA? TIA stands for transient ischemic attack. Stroke symptoms that improve without causing damage to the brain. They don't cause infarction. These are transient symptoms which improve. The old definition, which was improvement in 24 hours, but it has been observed that many patients, they have brain injury which is evident on MRI, especially the diffusion method MRI, after less than an hour, even if symptoms are improved. And some patients, they can have symptoms longer than 24 hours without brain injury. So this is a little bit controversial regarding the timings. Even brief TIAs, they predict increased risk of upcoming stroke. When a patient has TIA, it means his risk of stroke in future is higher than those who never had a TIA. TIA is an acute loss of neurological function caused by an ischemia with symptoms lasting minutes to hours. By definition, it is less than 24 hours. Annual incidence of out of 10,000 people occurs in 10% of the patient prior to the development of a stroke. Now, the pathogenesis of TIA involves either it is artery to artery emboli. What does it mean? Like there is proximal neck vessels, extracranial ICA, internal carotid artery in the neck, and there is some anteromatous plaque, and the plaque debris, it just moves from the breaks from this main plaque and it goes into the brain vessels, or it is cardiac emboli originating from the heart. They may be from the LV clot if there is a left ventricular clot formation, which is a complication of acute MI or dilated cardiomyopathy, and it may be due to atrial fibrillation. So the clots can come from either the artery, either it is an artery to artery embolism or it is cardioembolism most of the time. And the pathogenesis of TIAs, they are usually the result of microemboli, and they may be caused by a fall in the cerebral perfusion. The cerebral perfusion is transiently decreased. It is not blocked all over, but it is decreased for a while because the embolus is small in size and it passes over and the symptoms are resolved. Fall in cerebral perfusion, dysrhythmia, maybe postural hypotension, decreased flow through the vital atheromatous arteries, and rarely SOL and subdural hematomas. They can cause episodes indistinguishable from the thromboembolic TIAs. Increased total red cell volume, it may also be a cause. Sometimes polycythemia patients, they do have symptoms like TIA due to hyperviscosity of the blood, and they may present with TIAs due to this tendency to form clots. Risk factors for TIA and stroke are same. So whatever are the risk factor for stroke are the risk factors for TIA. The list is little short here, and there is a detailed list in stroke part. Hypertension, dyslipidemia, smoking, alcohol, diabetes, positive family history of stroke, atrial fibrillation, ischemic heart disease, patient taking hormonal pills like progesterone, estrogen, obesity, atherosclerosis because of any cause, whether it is extracranial, as I told you, or maybe intracranial atherosclerosis, all are the risk factors. Now, clinical features of TIA, these episodes, as these are transient, diagnosis is made on the basis of history, because when the patient usually presents to you, the episode has passed, it has resolved, symptoms have resolved. Onset is rapid, within seconds or minutes. It is variable but full resolution in less than 24 hours. And different clinical disturbances can occur depending on which part of the circulation is involved, whether the anterior or the posterior circulation. And the TIAs in the anterior circulation, they have a more serious prognosis. From the anterior circulation TIA, we will discuss those symptoms which are specific to anterior circulation. There are some symptoms which are common to both anterior and posterior. Some are specific for anterior, some are specific for posterior. So these are the symptoms which are common to anterior circulation, specific for anterior circulation. Number one is hemorrhagia fugax, that is fleeting blindness, loss of vision in one eye like a shutter coming down. It is often due to passage of emboli through the retinal artery. It may be first clinical evidence of internal carotid artery stenosis. Second is aphasia or dysphasia, again due to anterior circulation, because the speech areas, they lie in the cortex, frontal and the temporal lobe, and the circulation which supplies the frontal and temporal lobe is anterior circulation. Part of the temporal lobe is supplied with posterior circulation, but that doesn't supply the speech area. Then there are certain features which are unique to posterior circulation, which include homonymous visual field loss, that is usually in the posterior cerebral artery or calcarine artery infarction, dysarthria, vertigo, diplopia, dysphagia, and these symptoms usually occur in combination. If a patient alone has vertigo only, isolated vertigo or isolated dysphagia or isolated diplopia, this is usually not due to TIA. This may be something else, because these symptoms, they usually occur in combination, because the brainstem is a compact area, and when a vascular territory is compromised, it's not possible that one structure is compromised and the other is not. So there is symptom complex, not a single symptom. When there is a single symptom, you should consider about other diagnosis. Then comes facial numbness, maybe quadriparesis, even hemiparesis, and sometimes there is transient global amnesia, which has an unknown path, usually occurs due to thalamic origin. Then we have certain features which are anterior or posterior circulation. They can occur in both. As I told, quadriparesis more for the posterior circulation, and unilateral weakness can occur in both. Face, arm, leg, either it is in isolation or it is in combination. Unilateral sensory loss affecting the face, arm or leg, either in isolation or in combination. And TIAs rarely lead to an alteration of consciousness. Remember this. TIA patient rarely lose consciousness or develop altered consciousness. If this is the feature, you should consider an alternative diagnosis. Now, examination, usually neurological examination, is normal if the symptoms have completely resolved. Serious examination, cardiovascular examination may elicit relevant signs like signs of long-standing hypertension, which include heaving apex beat, loud A2 component of the second heart sound, and retinal changes of hypertensive retinopathy, arrhythmias like irregular pulse you can pick, heart murmurs can be there, heart failure signs can be there like pill edema, hepatomegaly, raised AVP, basal craft, third heart sound, gallop rhythm, carotid bruise may be there, and there can be loss of the peripheral pulses due to atherosclerosis, and it is an indirect evidence that patient has peripheral vascular disease, so he may be having central vascular disease as well, central atherosclerosis as well. In the differential of TIA, usually TIA is a clear-cut diagnosis, and diagnosis can confidently be made on history and keeping in view the risk factor. Similar symptom may be produced by migraine, and it is slowly progressing. It is usually with positive symptoms like paresthesia, the numbness in the arm, and scintillating scotomas rather than the blindness, flashing lights and all. So these are positive symptoms, and headache is a part of it. Then partial seizures, they have shorter duration with similar recurrence, because these seizures can occur with negative symptom also. It's not necessary that seizures should have tonic-clonic activity all the time. They can present with hemi-body numbness, maybe hemi-body weakness, which resolves. The negative symptom less common in seizure but can occur. Hypoglycemia, it can produce similar transient neurological deficit simulating TIA. Should always rule out hypoglycemia. Regarding the workup, actually workup is not part of my lecture, but just to give you an overview, all the baseline tests are required: CBC, ESR, C-reactive proteins, urea electrolyte, blood sugars, fasting random, HbA1c. Need to check lipid profile, and we need to check workup for some infection, because infections can also cause arthritis. But this actually depends on your whole history and the clinical scenario, because this whole workup is not needed in all patients. You start with the baseline, you rule out the um, atherosclerotic phenomena in the extracranial or intracranial vessel. You rule out the cardioembolism with echocardiogram, and atherosclerosis, you do Dopplers of the vertebral artery, carotid artery, you look for lipids. And when you rule out these common causes, then you go towards vasculitis, or if it is evident from the history, like patient has frank symptoms of SLE, joint pains, oral ulcer and all, then SLE is your first thought. But if not, then it comes lower down the list. And then there is syphilis serology, there are clotting studies, there are certain congenital thrombophilia like protein CNS deficiency, antithrombin 3 deficiency. All these should be ruled out when the major causes are already ruled out. In those patients where your differential diagnosis include a space occupying lesion or partial seizure, neuroimaging is advised. When you have doubt about it, that it can either be a brain tumor or maybe some partial seizures, you need neuroimaging. Now, this is secondary prevention of TIA. It means how to prevent further TIAs, and in this way you will be preventing a stroke. So this is sort of secondary prevention of TIA. Secondary prevention we call when the episode is occurred once and then you are preventing further episodes. And primary prevention, when no such episode has occurred before but you are preventing it. So this is sort of primary prevention of a stroke, because patient has not developed a stroke before. He had TIA, we are preventing TIA as a secondary prevention, and we are preventing stroke as a primary prevention. So control of hypertension, it reduces stroke rate by 40%. You have to control the risk factors like diabetes, sugar control, stop the smoking, moderating the alcohol intake, and low fat and modified DASH diet, which we call. Control of hypercholesterolemia, and it may reduce the atheoma progression, and this reduces the stroke risk. Coronary artery disease and MI, the most common cause of death post-stroke. These are the most common causes of death post-stroke. Management of TIAs, what are we supposed to give to the patient? Antiplatelet therapy, statins. These are the two basic things that we will give the patient, but we have other options as well. Aspirin 300 mg daily should be given as soon as the diagnosis is made, and reducing to 75 mg after several days. And there are so many thoughts about it. Some studies say that aspirin 300 is start and then switch to 75. Some are saying continue with the higher doses. Some are saying continue with 2 antiplatelets. So it depends, and it is a little beyond the scope of this discussion. Then comes statins. We have various forms of statins with us, which are lipid-lowering drugs. We have atorvastatin, simvastatin, and rosuvastatin, and we have other groups as well, which lower specifically the triglyceride, like the fibrate group, which include fenofibrate and gemfibrozil, and then we have ezetimibe, which is inhibiting the cholesterol absorption from the gut. So we can either give in isolation or in combination, and depending on the patient's type of dyslipidemia. Okay. Next is anticoagulant. Now, every patient of TIA does not require anticoagulant. It should be considered only if the patient has atrial fibrillation, mitral stenosis, recent myocardial infarction, cardiomyopathies, or other dysrhythmias. With TIA with atrial fibrillation, the risk of future stroke is reduced from 12% per year to 4% per year with anticoagulation to an INR of 2 to 3. So, in a patient with AFib and TIA, anticoagulation is mandatory. The risk of future stroke, now you have to weigh the risk-benefit ratio. You have to assess if the patient is elderly, he may have the risk of falls. If he has history of peptic ulcer disease, there is GI bleed risk or compliance issues and the treatment monitoring. Are you able to do that? The risk benefit ratio is always wait before you start any patient on anticoagulant, because these patients, they usually have multiple risk factors. Some of them have renal impairment, so anticoagulation may cause further problems, because these CKD patients, they already have coagulopathies because of various factors. So this anticoagulation has to be considered for each patient separately, keeping in view their whole clinical picture, their risk, and everything. Then comes surgical measure, which include internal carotid and endarterectomy. It is recommended in TIA patients who have internal carotid stenosis of more than 70%, and successful surgery reduces the risk of further TIAs by 75%. Surgical mortality is 3%, but it varies on the different surgical setups. And we have another option also, like you must have heard about coronary angioplasty. So we have an intracranial carotid angioplasty as well, sorry, not intracranial, extracranial carotid angioplasty, which is percutaneous transluminal angioplasty, stenting, which we called CAS, carotid artery stenting, or CAS, which is an alternative procedure if any patient has contraindication to the open surgery or endarterectomy. Then there are types of stroke: ischemic, we have intracerebral hemorrhage, mostly ischemic, 85%. Then we have bleeding into the brain, which is 10%, intracerebral hemorrhage. Then we have subarachnoid hemorrhage, which is bleeding around the brain, and that is 5%. The most common is ischemic stroke. Now the types of vascular events, I would call it vascular event, because when we say stroke, it goes towards ischemic stroke. It's now mostly considered for ischemic stroke. So this is all like vascular events, which can be either ischemic or hemorrhagic. 80% are ischemic, which can be thrombotic, embolism, or due to hypoperfusion. 20% are hemorrhagic, which can be either intracerebral hemorrhage or maybe subarachnoid hemorrhage. Now we have certain non-modifiable risk factors like race. You cannot modify anyone's race. African Americans and Asians are at increased risk. Male gender, increased risk. Family history of stroke, there is probably some genetic inheritance, and history of stroke or MI, previous history. So these are the non-modifiable risk factors of stroke. Okay, now we have modifiable risk factor like hypertension. You can control it with medications, and diabetes, dyslipidemia, smoking. Patient should be asked to quit smoking. Risk for embolic event in heart or carotid disease, we can give anticoagulants, and there are other, again, repetition of the same: obesity, insulin resistance, sedentary lifestyle, increased alcohol consumption, heart failure or ischemic heart disease, vasculitis, migraine, even hypothyroidism indirectly by causing dyslipidemia. Then sleep apnea syndrome, again obesity, hematological disorder like hypercoagulation or emboli in polycythemia, or in conditions like Waldenstrom microglobulinemia, there is hypercoagulability. And then predisposition for thrombotic event, that is the congenital problems, hyperhomocystinemia, protein CNS deficiency. Then we have female hormones like progesterone, estrogen pills. So again, there is repetition of the risk factors. Now the ischemic strokes, they are classified as large vessel strokes, and the pathophysiology involves Burko's triad. There is blood vessel injury, and there is stasis or turbulent blood flow, and there is hypercoagulable state. So these one factors or more than one factor, they act together, and then they cause the stroke or increased number of platelet, deficiency of anticoagulation as in hereditary thrombophilias, presence of procoagulation factors, CA malignancy. These are hypercoagulable state, and they increase the risk for a stroke. It can either be a large vessel embolic stroke, like the emboli are coming from the heart, either from the valves, like in atrial fibrillation or the prostatic valve, infective endocarditis, dilated cardiomyopathy or atrial myxoma or LV clot. These are all causes of cardiogenic embolism. Then either the clot is from the arterial circulation, as I've already mentioned, artery to artery embolism, atherosclerosis of the carotid, either there is arterial dissection or either there is vasculitis. These can all cause artery to artery embolism. Then venous circulation, well, if a patient has DVT, for example, now you would say if the clot dislodges from the DVT, from a deep veins in the legs, it will go into pulmonary circulation. Why would it go to the brain? There is an explanation. There can be a patent foramen ovale. There can be right to left shunt, and those impelli which are landing in the right side of the heart, they can cross through that shunt and on the left side of the heart, and then they can go into systemic circulation and brain. So that's very simple. And infections like syphilis and tuberculosis, they're one of the causes of a stroke. For understanding the stroke in the anterior and posterior circulation and different types of stroke syndromes, you need to have an idea about cerebral and vascular anatomy. Now, the vascular circulation is divided basically in anterior and posterior circulation. And the origin of anterior circulation is a carotid system which supplies 80% of the brain, optic nerve, retina, frontoparietal, and anterior temporal lobe of the brain. And rest of the brain is supplied by posterior circulation. Now, the common carotid artery divides into internal and external carotid artery at angle of the mandible. It terminates at anterior and middle cerebral artery at the circle of Willis, and then is ophthalmic artery, which is first branch of ICA, which supplies the optic nerve and retina. Here you can see this is external carotid, this is internal carotid, and this is dividing into the MCA and the SEA. And this is anterior communicating artery, this is posterior communicating. Different parts of the carotid artery, cervical segment, petrous, cavernous, and supraclinoid. You don't need to remember all that. And these are the other smaller branches of the ACA, anterior cerebral artery. Then we have pericallosal arteries as a part of branch of the anterior cerebral artery. Then we have recurrent artery of Hubner. Ophthalmic is direct branch of ICA. So this is overview of anterior circulation. Now you can see the parts of the brain which anterior circulation supplies. This is the area of supply of ACA. It is the medial part of the frontal lobe, which is basically controls the leg, motor power of the leg. And then we have middle cerebral artery. Middle cerebral artery, frontal lobe, parietal lobe, and anterior temporal lobe is supplied by the middle cerebral artery. And the posterior cerebral artery, this is not part of anterior circulation, so we will not discuss it here. But just for your knowledge, it is supplying the occipital lobe and the medial temporal lobes. This is posterior cerebral artery. It also supplies thalamus and midbrain. So posterior cerebral artery is part of posterior circulation, not anterior circulation. Now the posterior circulation, it supplies 20% of the brain, but that 20% of the brain lies the brainstem, and there are very compact structures, and it produces a lot of neurological deficit even with a small infarction. And this is basically derived from vertebral arteries. Posterior circulation supplies brainstem, cerebellum, thalamus, auditory centers, and visual cortex. Here you can see this is vertebral artery. Two vertebral arteries, they join to form the basilar artery, and the basilar artery's last branch, at which continuation is posterior cerebral artery, and in between it gives various branches which include superior cerebellar artery, pontine artery, anterior inferior cerebellar artery. So this is all posterior circulation. Here comes your anterior circulation, the MCA, and the posterior communicating artery is formed. This is the circle of Willis, which is formed by anterior and posterior circulation combined. Now, first of all, you have to localize the lesion, whether is it in the anterior circulation, whether it is in the posterior circulation, is it cortical, is it subcortical. So if you recall my lecture about localization, it will be very easy for you to understand this part, because in anterior circulation, large vessel means it is going to involve the cortex. You need to look for the cortical sign. What are those signs? Aphasia, when the dominant hemisphere is involved. If not, you should look for apraxias and agnosias, as I've already described in that lecture. And then anterior circulation, small vessel, there will be no cortical signs on exam. There will be no dysphasia, aphasia, there will be no apraxia, agnosia. They can simply present with either the sensory signs or the motor signs, hemiparesis or hemisensory impairment. Then comes posterior circulation, again crossed or bilateral sign, already explained so many times. Brainstem infarction or brainstem lesion, cranial nerve deficit will be on the same side and motor deficit will be on the opposite side, because the cortical spinal tract cross. Okay, and they will have cranial nerve findings. They may have condylatal hemianopia if the occipital lobe is involved. And then we have watershed areas. Look at the watershed and border zone areas, and these areas are usually involved by hypoperfusion. Now, what are the watershed cerebral infarctions? I need to clarify this. This is also known as border zone infarct, and it occurs at the border between the cerebrovascular territories, the border area between the various cerebrovascular territories, where the tissue is farthest from the arterial supply and thus most vulnerable to reduction in perfusion. So any cause of hypoperfusion like hypovolemia or cardiogenic shock can lead to watershed infarction. It has been proposed that both episodes of hypoperfusion and microemboli from the inflamed plaques they play a role in pathophysiology, although the latter is less well established. It's mostly due to hypoperfusion. This is a MRI diffusion weighted image which is demonstrating a watershed infarct. It is between the ACA and MCA and MCA and PCA, this one. So this has occurred most probably due to a state of shock because of any reason. Now we will further continue with the localization of the stroke. MCA. How is MCA infarction characterized? Arm and face weakness is more than the leg weakness. And if there is left MCA infarction, left hemisphere dominance, there will be aphasia or dysphasia. Right hemisphere, right MCA, neglect, topographical difficulty, graphesthesia, dressing apraxia, construction impairment. These are all explained in the lesion localization lecture. You need to recall that because that part, lesion localization, is very important for all this understanding of different syndromes. ACA, leg weakness more than the arm weakness. Cognitive, patient can be mute. If there is especially the bilateral ACA infarction, patient may be having disinhibition, like personality changes may be there and disinhibition of maturation will be there. There can be incontinence. This is usually with bilateral ACA infarction. Then we have PCA infarction, and they may cause homonymous amyloidopia because the supply is going to the visual cortex. Cognitive there can be memory loss, there can be confusion or alexia. PCA supplies the thalamus also, so there is some medial temporal lobe, so there can be problems with the memory. And vertebral and basilar artery, again they are going to supply the brainstem, so you will get brainstem sign. And if the cerebellum is involved, you will get ipsilateral cerebellum signs. Now this is a CT scan which is demonstrating early infarction and a subacute infarction which is after 4 days. An early infarction, you can see subtle blurring of the, now compare the right and left side. This side you can see clear sulci gyri. Here you can see the sulci gyri and the gray-white differentiation is lost. And sulci are effaced. You cannot properly characterize them. This is early sign of infarction. And here you can see after 4 days there is proper established hypodensity involving the frontotemporal and parietal lobe as well. Some part of the frontal, temporal and parietal. This is likely an MC infarction and it is causing midline shift and a mass effect as well. Ventricle is effaced. You can see lateral ventricle. You cannot see the left side of the frontal horn of the lateral ventricle. That is because of the mass effect. And this is DW image, diffusion weighted MRI, and here it is CT. CT is normal, and when we went for the MRI DWI image, diffusion weighted image, is showing a hyper bright or hyper intense signal which is consistent with an acute infarction, and this diffusion restriction lasts for about 6 days and after 6 days it disappears. Now these are the differentiating features between anterior and posterior circulation in stroke. I hope that it has been very clear that which features are suggestive of anterior circulation and which are suggestive of posterior circulation. But in posterior circulation you will get vertigo and unsteadiness, and you will get crossed hemiplegia. You may get bilateral deficit like quadriparesis can be there, cerebellar signs are present, and brainstem signs, cranial nerve palsies. INO can be present, internuclear ophthalmoplegia, gaze deviation to the paralyzed side can be present. Dissociated sensory loss can be present. Sensory loss over first and second division over the face can be present. Hornets is a part of posterior circulation but not of anterior circulation. So this is just a simple chart which is emphasizing on which findings are suggesting that the stroke is posterior circulation and not anterior circulation. Anterior circulation, again we will go to cortical, subcortical. If it is cortical, you will get cortical sign. If it is subcortical, you will get simple hemiparesis or hemisensory deficits. Now, just to explain few syndromes of a stroke, I need to show you the structures which are contained in various parts of the brainstem. This is medulla, and here you can see the pyramids, and we have this spinothalamic tract here, and we have certain vestibular nuclei. We have vagus nucleus. The hypoglossal nucleus is medially placed, most medially placed, and we have this medial lemniscus, which is again most medially placed. This medial and lateral is going to differentiate between different strokes. Hypoglossal nerve, see, this is again medially placed. Inferior olivary nucleus, this is lateral, and this is vagus nerve, And we have corticospinal tracts or pyramids as well. Pyramids, yes, pyramids contain the corticospinal tracts. These are different structures which are present in the medulla. So I think this is little about the neuroanatomy of the medulla. We have 9th, 10th, 11th, 12th cranial nerve nuclei in the medulla. See, this is vagus. And here we have the hypoglossal, the spinothalamic tract, and so many compact structures there in the medulla. Now this is lateral medullary syndrome because of the it's also caused pica syndrome, posterior inferior cerebellar artery infarction. It is basically there is ipsilateral 9/10 nerve palsy. There are cerebellar sign. This part is involved. See, so vagus has gone, and the 9th, 10th nerves are gone, and we have cerebellar signs because of these vestibular nuclei are involved, and certain tracts are involved, and the Horners because the sympathetic fibers are also involved. This is sympathetic tract fibers, see, and it is also placed laterally, and when the area is infarcted, this is going not to function, so it will give rise to Horner syndrome. Impaired pain temperature in touch on the upper half of the face because of the this medial lemniscus, and contralateral pain and temperature over the body because of the spinothalamic tract. Here it is, lateral spinothalamic tract. This is involved. So the impaired pain and temperature over the body and the medial lemniscus, when it is involved, then it causes the pain temperature impairment on the face. This is lateral medullary syndrome, which is also called lateral medullary syndrome of Wallenberg syndrome, pica syndrome. These are all names for it. Now this is medial medullary syndrome. Medial medullary syndrome, it is very simple. It is involving the pyramid, that is the corticospinal tract, and the medial lemniscus. So what it would cause? Contralateral hem and also the hypoglossal nerve. Don't forget it. Cranial nerve deficit and brainstem will be on the same side, that is ipsilateral 12th nerve palsy, contralateral hemiparesis because it is causing this corticospinal tract is involved, and hemianesthesia is sparing the face. Now this is pons, and we don't need to go into the details of all the pontine syndrome, but you should know which structures are embedded in pons, that is corticospinal tracts are there, 6th, 7th nuclei, and vesicles are there, and there is superior cerebellar peduncle. So when this part is involved, it can even cause contralateral ataxia. This is not cerebellum itself, this is superior cerebellar peduncle. When the peduncle is involved, the ataxia is contralateral. And we have reticular formation, and we also have a middle cerebellar peduncle here. We have a spinal thalamic tract, and we have bundle of corticospinal and corticonuclear fibers, and there is abducen nerve, facial nerve, medial lemniscus. Motor nucleus of facial nerve is lying here, nucleus of abducen nerve is here. It curves around this just a minute, abducen facial nucleus, it is curving around this abducen nucleus. Medial long fasciculus, cavity of fourth ventricle, these are all present in the pons. Now the pontine strokes, they give rise to, if it is a unilateral infarction, it will give rise to contralateral hemiparesis, and there may be 6th nerve palsy or 7th nerve palsy, or both 6th and 7th nerve palsy. There may be ataxia on the contralateral side. In midbrain, the structure you should know, corticospinal tracts are there, and we have red nucleus here, we have substantia nigra. Also the important structure, nucleus of oculomotor nerve is lying here, and we have mesencephalic nucleus, we have cerebral aqueduct, multiple structures, spinal lemniscus, trigeminal lemniscus, medial lemniscus, temporopontine fibers, corticospinal, so lots of tracts and fibers, and motor tracts are there. Main things is motor tract, and it has this red nucleus, and third is the oculomotor nerve. So Weber syndrome, it is occlusion of perforating branch of the posterior cerebral artery, and the clinical features are, as you can see here, this part is involved, and it is involving the third nerve, ipsilateral third nerve palsy, and the corticospinal fibers are involved, so it will give rise to contralateral hemiplegia. This is very simple. Third nerve on the same side, contralateral hemiplegia because corticospinal tracts are involved, so they will cross rotate, hemiplegia will be on the opposite side. Then there is Benedict syndrome, which is occlusion of perforating branch of PCA. Now this part is involved again. The third nerve is gone, as you can see, and there can be contralateral cerebellar ataxia, or there can be hemiparesis. It depends. If there are corticospinal or more involved, then it will be hemiparesis, and if not, then there can be ataxia. Now this is the MRI of various brainstem infarctions. Like this is medullary infarction, lateral medullary infarction, okay, and this is pontine infarction, left pontine infarction. You can see this is following such a demarcated area, and it is following the vascular territory. It is not crossing the midline. This is the characteristic of infarctions. They follow the vascular territory and they do not cross the boundaries to the opposite side. And this is the midbrain infarction. You can see here dotted infarcts. It will be clear on the diffusion weighted if the patient has come within 6 days. Like this one is a diffusion weighted image. This is T2 and this is again T2 image. Now comes thalamic stroke, and which is causing contralateral sensory loss, and there can be spontaneous pain, which is known as Dejerine-Roussy syndrome, associated with thalamic strokes. There may be movement disorder associated with thalamic stroke, like chorioathetosis, ataxic tremor may be present in some time. Mild hemiparesis can be present. Now there is occipital lobe infarct, occlusion of the left calcarine. If isolated left calcarine is obliterated or occluded, then it will simply cause contralateral hemianopia, left calcarine, right hemianopia. And if there is involvement of the both, then what will happen? Patient will be blind. There will be cortical blindness with preserved light reflexes because the cranial nerves are intact. Light reflex is carried by afferent through the optic and efferent through the oculomotor. So both of those nerves are intact, so pupils have to be normal, but the visual cortices are gone. Bilateral and occipital visual cortex infarcts will cause blindness. Now there is hemorrhagic stroke, which can be traumatic and spontaneous. Spontaneous is usually due to hypertensive, small vessel disease, and amyloid angiopathy in old age. Usually they are very older people, more than 60-70 years of age, can be due to aneurysmal rupture, and these are usually lobar hemorrhages. AVM rupture, aneurysmal rupture can be lobar, can be subarachnoid type hemorrhage with lobar hemorrhage. AVM usually lobar hemorrhages lead into the tumor, which is also again causing stroke-like presentation. Cocaine and amphetamine use, they cause sudden surge in the blood pressure and they can lead to vascular insult like intracellular hemorrhage or even ischemic stroke. Now the intracellular hemorrhage in this picture, again same division of the causes: hypertension 36%, aneurysm 36%, AVM 11 and 17 are other. Other include bleeding into the tumor, hypocoagulable. These are the coagulopathies: hemorrhagic infarction, iatrogenic, and trauma. Now the hypertensive ICH, there is a spontaneous rupture of a small artery deep in the brain, and the typical sites for hypertensive hemorrhage are mainly four: basal ganglia, thalamus, cerebellum, and pons. Basal ganglia are caudate and putamen, and globus pallidus, and this is thalamus, and cerebellum and pons. Mostly in basal ganglia, pons is involved. Putamen is involved. Pons is brainstem, and cerebellum is one side, thalamus is another side. Typical clinical presentation: patient usually awake with abrupt onset of symptom with acute decompensation. Very sudden onset, usually associated with headache, altered consciousness. Basal ganglia hemorrhage, contralateral hemiparesis can be there, hemisensory loss can be there, homonymous hemianopia can be there because the visual fibers, these are disrupted, and conjugate deviation of the eyes toward the side of the bleed or downward deviation can occur, especially in the when it extends to the thalamus, and altered level of consciousness can be there, ranging from stupor to coma. And this is a CT scan depicting pontine hemorrhage, typical hypertensive hemorrhage in the left putamen, not pontine, this is left putamenal hemorrhage. Sorry, I'm making a mistake of calling putamen as pons. Now cerebellar hemorrhage, vomiting more common in ICH than subarachnoid hemorrhage or ischemic CVA. Is more common, and vomiting, especially ataxia, eye deviation can be there, small sluggish pupils can be there, and altered consciousness can be there. This is a cerebellar hematoma which is extending into the fourth ventricle, and the risk is of developing hydrocephalus. Pontine hemorrhage, pinpoint pupils, are a feature of pontine hemorrhage, abrupt onset of coma, decerebrate posturing or flaccidity, ataxic breathing pattern. These are all features of pontine hemorrhage. Here you can see this is a pontine hemorrhage. The diagnosis, to perform imaging to confirm your diagnosis, and CT is widely available, which is done quicker and can rule out the hemorrhage immediately. MR takes a lot of time and it has various sequences and it can be performed for early infarction and its causes, but CT is the first thing to go for when you are ruling out whether it is infarction or hemorrhage, and after that you can proceed with MRI. So this was about TIAs and stroke and their risk factors and their clinical presentations. I hope I have made it clear, but if there is any, because this was a little more, I mean, there were a lot of things to understand and to grab. And the previous lecture of localization, it was very, very important as far as the concept of differentiating between cortical, subcortical, brainstem, and brainstem syndromes is there. So localization is very important. And if you have grasp over that lecture, then this wouldn't be any problem with diagnosing categorizing the stroke syndromes. And still, if there are any queries, I'm there to answer that. And Allah Hafiz till next class.